Dear students and colleagues, the topic of presentation today is a cardiogenic pulmonary edema. And this is a disease or syndrome which is characterized by the development of acute respiratory failure associated with the accumulation of fluid in the lungs' alveolar spaces due to an elevated cardiac filling pressure. All cardiac diseases characterized by an increasing pressure in the left side of the heart can cause cardiac pulmonary edema. About pathophysiology shortly, pulmonary edema refers to excessive fluid accumulation in the interstitial and alveolar space of the lungs due to an imbalance among the so-called Stalin forces, an increase of alveolar capillary barrier permeability, or a blockage of the draining lymphatic system. Cardiogenic pulmonary edema is the most common cause of respiratory failure and results from increased cardiac filling pressure and alveolar epithelial barrier breakdown due to factors like inflammation, leukocyte infiltration, pro-coagulant process, and ion channel modification by reactive oxygen and nitrogen species. High capillary pressure for an extended period can also cause barrier disruption, which implies increased permeability and fluid accumulation into the alveoli, leading to edema and atelectasis. The breakdown of the alveolar epithelial barrier is a consequence of multiple factors that include dysregulated inflammation, intense leukocyte infiltration, activation of procoagulant process, cell death, mechanical stretch. Reactive oxygen and nitrogen species can modify or damage ion channels such as epithelial sodium channels, which alters fluid imbalance. Factors which are associated with the cardiogenic pulmonary edema are uncontrolled arterial hypertension, myocardial ischemia, arrhythmias, more common atrial fibrillation, ventricular tachycardia, and others. Systemic infection, pulmonary infection, pneumonia, and other infection can provocate cardiac pulmonary edema. Severe emotional or psychological stress, vigorous intravenous fluid administration, and worsening renal failure. Severe anemia from another factors can be non-compliance with medication as diuretics, thyrotoxicosis, medications that reduce contractility, such as anti-arrhythmic drugs, calcium channel blockers, beta blockers, anthracyclines, any chemotherapy agents. Cardiac toxins, it's alcohol, cocaine, use of sodium-retaining medication like anti-inflammatory drugs, steroids, excessive salt and water intake. It's a more common factor which can be associated with this edema. Signs and symptoms of cardiogenic pulmonary edema include tachypnea, which may be associated with the use of axillary bracing muscles, tachycardia, jugular venous distension. Patient may be sitting upright and usually appear anxious and diaphoric with a cyanosis of lips. Auscultation of the lungs generally reveals fine crepitant rales, but wheezes may also be present. Rales are usually heard at the basis first, and they progress to the apices as the condition worsens. An absence of rales doesn't imply a lack of pulmonary venous pressure elevation. Auscultation of the heart may be challenged in an acute scenario when valvular abnormalities result in cardiogenic pulmonary edema. Murmurs may be audible and auscultable. Pulse oximetry, oxygen saturation in ambient air is usually less than 90%. Hypertension is often present due to the hyperadrenic state. Hypertension could indicate severe left ventricular systolic dysfunction and cardiogenic shock. Low perfusion is characterized by decline in urine output, cold extremities, skin pallor or mottling, and decreased cognitive function. Hepatomegaly, hepatojugular reflex, ascites, peripheral edema may be found in patients with concomitant right ventricular failure and congestive heart failure. In patients with a chronic heart failure, peripheral and pulmonary edema frequently coexist together. Leg edema is frequently evident in both legs, symmetrical, particularly in the pre-tibital region, and ankles in ambulatory patients. Sacral and upper thigh edema can be detected in patients who are bedridden. The correct approach to patients with cardiac pulmonary edema should include a detailed medical history and a physical examination to evaluate signs and symptoms of cardiogenic pulmonary edema as well as potential causes. For patients should be done initial testing, which includes ECG, chest X-ray, lung ultrasonography, lab test, comprising arterial blood gas and cardiac enzymes. ECG signs may be myocardial infarction, ischemia, arrhythmias, pericardial disease. Cardiac rhythm abnormality also may contribute to pulmonary edema. Atrial fibrillation may lower cardiac output and worsen edema, either because decreased ventricular rates with inadequate filling or the loss of consumption fraction, ejection fraction of heart. Radiological signs in cardiogenic pulmonary edema include inverted distribution of blood flow in the lung, basal and homogeneous distribution of edema from chest wall to heart, enlarged vascular pedicle and azygous widths, normal or small lung volumes, and the presence of peribronchial coughing, septal lines, and effusions. When diffuse parenchymal lung disease is being considered in the differential diagnosis, computer tomography scans of the chest can have an important role for diagnosing of comorbidities and associated diseases. The main findings in cardiogenic pulmonary edema are ground glass opacities, thickening of major fissures, interstitial edema, and interlobal peribronchovascular thickening. Pulmonary ultrasonography can identify B-lines or comet tails, which are vertical hyperechoic reverberation artifacts that arise at the pleural line and extend through the lung. Second level diagnostic tests are natriuretic peptide level and echocardiogram. Echocardiography is allowed to measure valvular, systolic, diastolic ventricular function, pericardial abnormalities. Diastolic dysfunction may be difficult to detect, and combination of cardiac and thoracic ultrasonography can help differentiate cardiogenic edema from acute respiratory distress syndrome or other causes when patient has acute hypoxic respiratory failure. Decrease left ventricle function, large inferior vena cava, minimal diameter more than 23 mm, left side pleural more than 20 mm can be a symptom for cardiogenic edema. Serial measurement of troponin levels are important to exclude myocardial infarction, myocardial ischemia. Elevated brain natriuretic peptide can support heart failure as the cause of pulmonary edema. And if mental status is abnormal, then toxin, we screen for electrolytes and serum osmolarity. One more method of evaluation patient with cardiogenic pulmonary edema, it can be thoracentesis that help confirm and differentiate pleural effusions are because of heart failure as the cause of transudal effusions are relatively few. Heart failure, hypoalbuminemia, nephrotic syndrome, Myers syndrome, hyperthyroidism, and sarcoidosis. Effective diuresis of patient with heart failure can convert a transudative effusion into an exudate. Pulmonary artery catheterization with measuring of the pulmonary artery occlusion pressure used to be a common diagnostic and management tool for a patient with pulmonary edema. And if summarizing, we can talk that the most common causes for cardiogenic pulmonary edema can be coronary artery disease, arrhythmias, myocarditis, non-cardiac infections. Acute valve syndrome includes acute mitral aortic regurgitation due to infective endocarditis, ischemic papillomass rupture, aortic dissection, and other disease. Ventricular septal rupture is one more cause for cardiogenic pulmonary edema. Stress or Takotsubo cardiomyopathy, volume overload, especially in acute renal failure, hypertensive crisis, overdosing of beta blockers or calcium channel blockers, scorpion venom, pheochromocytoma, cardiac tamponade. And it's not all list of situation and disease which can be accompanied with a cardiogenic pulmonary edema. In plan of management patient, of course, necessary to identify the special disease which leads to this complication, and initial treatment of CPA is a supplemental oxygen or non-invasive ventilatory support for sure adequate oxygenation. Non-invasive ventilation should be considered early in the treatment of this cardiogenic pulmonary edema. Supplemental oxygen treatment and assisted ventilation should be provided as needed to treat hypoxemia if saturation of oxygen less than 90%. However, oxygen is not recommended as a routine treatment in patients with hypoxemia, as it may cause vasoconstriction and reduce of cardiac output. Early intravenous loop diuretics treatment is considered the cornerstone of CPA in order to decrease cardiac preload. The aggressiveness of diuretic treatment depends on the patient's hemodynamics and volume status. Diuretic and vasodilators like the nitroglycerin are used for pulmonary congestion. Hypoperfusion requires treatment with inotropes as dobutamine or milrinone, or occasionally vasopressor as norepinephrine. For patient, we should prophylact venous thromboembolism with the anticoagulant. Patient, we recommend sodium and fluid restriction, and patient with persistent symptoms and diuretic resistant may benefit from additional approach as a beta agonist, albuterol, pentoxifenone. If summarize information about this presentation, the key messages is that Cardiogenic pulmonary edema is a life-threatening condition leading to compromised gas exchange and acute respiratory failure. The initial events in CPE involve hemodynamic pulmonary congestion with high capillary pressure and increasing fluid transfer out of capillaries into the interstitium and alveolar space. CPE is bilateral in most of cases. Patients with a CPE represent a heterogeneous population. Common causes are myocardial infarction, unstable angina, atrial fibrillation, atrial flutter, ventricular tachycardia, myocarditis, hypertensive crisis, non-cardiac infection, renal failure. The conventional management of CPE usually involves diuresis after load reduction, non-invasive ventilation. Patient with a symptom abnormal chest X-ray diuretic resistant may be treated from alternative approach to management such as beta antagonist and pentoxifylline. Thank you for attention.